So thank you to our partners at SAGE and the Pride Center of Edmonton. And before I introduce our speaker, I'd like to acknowledge that we are located on Treaty 6 territory and respect the histories, languages, and cultures of the First Nations, Métis, Inuit, and all First Peoples of Canada, whose presence continues to enrich our lives. Two housekeeping items. First, I'd like to caution you that today's session will be recorded. If you would prefer your image not be used, please turn off your camera. And second, we like our weekly meetings to be a safe space. So I'd like to remind you of a couple of items. Please respect the speaker by remaining muted during the talk. We'll unmute you for the Q&A following the presentation. Please be mindful of our time limitations and keep your questions and comments as brief as possible so that everyone can participate. Everyone who wishes to will be given an opportunity to ask a question before individuals who have already spoken will be called back again. And please respect the confidentiality of personal information. And now, with great pleasure, I'd like to introduce our speaker for the day. Jedediah Jed Wilson is a registered provisional psychologist and Canadian certified counselor in Edmonton, Alberta. Currently, they hold private practice alongside their work with the Edmonton Mennonite Center for Newcomers, focusing on gender diversity and sexual health. Jed has a passion for trauma and disassociation-informed care, best practices in substance use, and promoting gender and sexuality health. Really looking forward to this. Jed, please take it away.
Very best. Hi, folks. My name is Jed. Thank you so much for having me at your weekly meetings. I really appreciate it. So today I'll be talking a little bit about self-care tied in with substance use and some things that don't necessarily look like substance use, but could also be, kind of, we talk about maladaptive coping mechanisms. So we'll be getting into that. Bit of a content warning. Some of the things that we'll be discussing, they have dark histories to them. And it's, if you need to step out, if you need to contact somebody, please do that. Don't feel like you have to sit through the presentation. That's, I wouldn't want that for you. The other pieces is I'll probably, I think the goal is to go talk for about 30, 35, 40-ish minutes. And then I'm hoping we can have a conversation at the end. Some questions, I'd really appreciate it. And I will go ahead and share my screen. We'll get this thing going. Oh, other thing. So apologies in advance. I will be paying attention to how loud I talk. I fall into the trap of therapist voice. So it gets very mousy sometimes. so my apologies for that. Can I get a thumbs up from somebody if people can see or if people can see and hear me? And that you guys can see the slides? Great. Okay. So formally called Self-Care and Safety Strategies on Substance Use in 2S LGBTQIA+ populations. My own little land acknowledgement. So I respectfully acknowledge that we are located on Treaty 6 territory, a traditional gathering place for the diverse Indigenous and First Peoples, including the Cree, Blackfoot, Métis, Nakota Sioux, Iroquois, the Dene, the Ojibwe, Saulteaux, Anishinaabe, Inuit, and many others whose histories, languages, and cultures continue to influence our vibrant community. Already been through this bit. I work as a registered provisional psychologist in private practice and with Newcomers here in Edmonton. Fairly new here. I moved here in August of last year, so this was my first Edmonton winter here. Not so bad comparatively to New Brunswick. Things are looking okay. And quick table of contents. Some of these things I'll be talking about, some of them I won't. It depends on the folks I'm speaking to. Like we won't be going over like theoretical orientations and things. That's kind of geared more toward for like when I'm talking with like other therapists. And also I don't want to put anybody to sleep. So we'll be skipping some of those slides. But if anybody would like me to elaborate on anything, more than happy to. Really what I'd like to focus on is kind of the end of the minority stress model, which talks about, the stresses that we hold quite close to our hearts and, disparity in stresses that we face as opposed to heterosexual populations, things like that. I'd like to talk a little bit about particular risks and then health promotion that are specific to our community, as well as adaptations in life care. So what does healthy self-care look like versus what are necessary life adaptations, and what do those things look like, and where is the space for those things? And then I'd like to end on harm reduction and what does that look like. And we'll start going through. I'm going to skip through some of these slides, so my apologies, please bear with me. I will, now that I'm thinking about it, I will start here. So I use SOGI diverse, sexual orientation and gender identity as kind of preferred verbiage. Every once in a while, I do use the verbiage queer and trans. I understand that that can be dicey for certain populations. If it is, please send me a message or just let me know. More than happy to not use that if that bothers somebody. And if I don't see it, because I don't think I can see my chat now that I'm thinking about it, if it could be brought up in the chat, if you get a hold of Eric or Larry or even Jan, if that's okay with you folks, I'd really appreciate it. Don't want to tick anybody off. Broadly, and this is something that I think we've all felt, the minority stress model is an interesting way of conceptualizing health, originally in the sexual health domains, but basically it positions, SOGI, diverse, queer people, trans people, what have you, to be kind of at the center of this like discrepancy and conflict between the values of a minority group and then the values of dominant society. And then the byproduct of this conflict considers things like, surviving hate-based victimization, discrimination, stigmatized identity. We'll be talking about that a little bit. What I really hope that this gets across is the concept of distal and proximal stressors. So like distal stressors are things that exist in the environment, ideally can be intervened upon in the environment when it's safe to do so. So discrimination, more systematic barriers, things you can like kind of reach out and physically touch. Those are those distal stressors. Proximal stressors I refer to as things that we hold close to our hearts. So that might be stigmatized identity. That might be not being comfortable in your own skin. That might be adapting some of the words that have been used against you. You know what I mean? It's basically that proximal stressors. That's what I think I do the most of my work with as a provisional psych, because it's untangling, the ways that somebody views themselves that they've taken on from systems around them, looking at how helpful and how hurtful those things are. So that's really like what I would like folks to focus on when we talk about minority stress. It's just those unique incidences that occur in our population a little bit more. Very specifically, it sets the stage for, and I think folks, kind of in the, especially in terms of sexual orientation, gender identity, it sets the stage for, at some point in our lives, we have to negotiate identity and, who am I and what does that look like? And am I okay with that? Minority stress positions that situation as potentially risky because, on the one hand, there is acceptance of self, very the best. What does that look like? On the other hand, if you're in a place where it's not condoned or it's not okay, or you don't feel like it's safe to, what we can see sometimes is outright rejection of identity and this unstable sense of self. Suddenly someone is torn between, well, I feel this way, but I don't know if that way can be expressed out in the open. So some people will go through identity modification. They'll kind of modify the pieces that they present to people. So some parts of the self get dampened. I think the verbiage nowadays is very much straight passing or cis passing, to try and just blend in with the people around you. And that gets tricky because that is a hard thing to cope with. You know what I mean? It's a hard concept to, well, I have to do these things to, blend in with the people around me, but blending in with the people around me means me not being me. So that's what I mean there for setting stage for risk. And specifically after that, it can now set the stage for different ways of coping. We'll talk a little bit about avoidance coping, and then also things like substance use or other behaviors that we engage in that aren't necessarily healthy. Like, say you take, for example, someone who has somebody who starts working 12-hour days, a hobby that somebody falls into that just they don't, they spend a good chunk of their day and they don't quite get out of, watching TV very frequently, movies, reading, those otherwise healthy things that we do taken to the extreme. That should also kind of be included there in substance use / necessary life adaptations. And I think they reflect a very human attempt to gain control over situations we may not have control over, especially when that sense of a lack of control is coming from inside. So we've talked a little bit about unique risks. So I will, the piece that I will focus on here specifically is community grief. I think the SOGI diverse population has seen obviously some dark times, and I think we still very much see the echoes of those things. In this case, I'm very much referring to HIV/AIDS crisis. And it's interesting hearing some of my colleagues who are my age very much conceptualize that as an American thing. When you go through kind of the timelines, it hit a lot of Canada, major metropolitan areas, I think more than others. So, Vancouver, Edmonton, Winnipeg, Montreal, Toronto, Halifax, areas like that. With that, though, I've talked a lot about this with some folks. There's a gap, you know what I mean? There's folks that are my age, kind of at the end of the millennials, and there's the Gen Zs, the millennials, the what's after me? Gen X, I think. It's kind of that, 30 to 40 age bracket, and a gap. And then you kind of move into, I believe the generation is either pre or kind of just during baby boomer era. So there is, I think reasonably so, still a lot of guilt that clings, or not guilt, survivor's guilt, stigma, and shame, because we're talking about events that I think started almost to a T 44 years ago. I mean, I was born the year that HART became available in Canada, so I think that this becomes tricky because for folks that I work with who are younger, it's very much like, how would you like to embrace yourself in society, and what does that look like, and how do we explore? And then for older folks who have lived through this, that doesn't always seem like an option, because either people feel like the government has kind of been against them, majority of the population has been against them. So our community, I think, is at quite an increased risk for community grief, and it can ripple through communities, especially if we lose somebody, especially where SOGI diverse communities are so tightly knit. The loss of someone or the harm to someone, it spreads very quickly across everybody in that community. So this is something, in terms of health promotion, this is something that I very much gear toward younger audiences. I also try and hope to gear it toward every audience, which is, nowadays we treat sexual orientation and gender identity exploration as natural human diversity. Exploration is common, encouraged, hoped, really. So that way somebody understands kind of the full breadth, full width of their sense of self. But also in mindfully engaging in knowing the difference between self-care and adaptations. So self-care are things that we do for ourselves that help us live in the world, that help us thrive in the world, that help us they make us feel like ourselves, they make the world make sense, they help in the short, kind of the intermediate and long term. It doesn't always have to be, doing yoga and taking a bath and kind of all the stereotypical like Pinterest or Instagram things that you see. If that is your jam, wonderful, love that for you. You know what I mean? But self-care can look like waking up and brushing your teeth. Self-care can look like getting out of bed, taking your medications on time, and getting like a piece of toast into you. Self-care can look like that, and then the great thing about it is it gets built upon. And self-care, those concepts, they never leave us. They go quiet. They don't leave. We can have moments where we walk away from self-care a little bit, which is totally normal as we flex and flow. But those things, they never leave us outright. Necessary life adaptations are an interesting creature because it almost looks like self-care. Those are ways in which we survive in this world. A little bit different than living. Surviving is very one-track mind. Need to get through this situation. And usually what it is we build adaptations around the things that are happening with us currently. It might look like avoidance. So not going to a medical appointment, disengaging with the community and pulling back. So some isolation behaviors. We talked a little bit before about some of those healthy behaviors taken to a more extreme. So, preoccupation with like books and TV shows, it might be work, it might be hobbies, things like that. Necessary life adaptations, they're interesting because I say to people, like, they're almost hypnotic. They tell you, the situation tells you need to hold on to these things to make your way through it. And it's all we pay attention to because we think, like, if I just do this, I will get through whatever situation I'm in. And then we stay with it. So those are traps that we can fall into sometimes. Also very human. Everybody has necessary life adaptations. And we'll be talking about that in a minute. And I think a little more, and I think that's pretty normal and expected. On adaptations and self-care, concept of what once worked, very simple model of how people avoid things. Let's say, someone is 12 and in school or in the community, they hear a word levied against them about their sense of self that is absolutely terrifying. So we witness an event or we feel an event. We organize a response to that event, which is, in this case, avoidance. I will avoid, I will suppress, I will distance myself from, get as far away from this thing as I can, this insult that has been directed at me. And then we get away from it successfully, so it's reinforced. The response was successful. Maybe I'm just going to not recognize my sexuality for a little bit because it's not a safe space to. And then we will repeat the behaviors. We repeat the behaviors, though, even when the situation doesn't call for it. Sometimes. I think very much of, it's a lyric from The Head and the Heart, which is a little cheesy, but please bear with me. The lyric basically goes, all we ever do is all we ever knew. And I think that's really useful in this circumstance because we do what we know. We don't always spontaneously think of new creative ways of managing a situation when we're feeling very stressed. That ability to be creative can be suppressed. Therefore, ideally, we engage in self-care. Self-care in this avoidance situation might be recognizing, I'm avoiding this. Got it. Just putting a word on it. Don't necessarily have to respond to it, but okay, got it. This is something I'm avoiding. This is something I'm pushing away. Might not be able to do anything about it now, but if I could in the future, what would I want to do about it? So that way you get that future orientation, that future direction. while there is minimal pressure to immediately act on that thing, provided you are otherwise safe, So as a definition, avoidance coping, it's that internalized or anticipated stigma or other pain that provokes avoidance of engaging with self-care specific to that stigma, like therapy, medical appointments, engaging with friends, what have you, specific to substances. And that self-medication hypothesis, it positions substances as a means of reducing negative or painful moods, so very commonly in our community, we see things like alcohol, poppers. It's like every 3 years, kind of waxes and wanes, like the phases of the moon. We see that quite common in contemporary society. I think that the big ones are things like cocaine, methamphetamines, stimulants, depressants like alcohol, and then some other hallucinogens like ketamine. We also see a lot of opioid use, a little bit less so in senior and aging populations. So I guess I'd like to, and I've spoken to this, but there's many other means of coping apart from substances, which is isolation, excessive exercise, excessive or restricted eating and dieting, things like that. Those things that we do that basically make us feel like we're taking control over the situation. They help in the short term. They may help in the intermediate term, but they don't always help in the long term. That's that concept of avoidance coping. So actually, I think I'll skip to the next slide because it talks about avoidance coping and a sense of self. There was a really interesting article that I read. It was in 2020, and if I remember this properly, it was a bunch of interviews about individuals, trans individuals, very specifically, I believe, who, interesting pool of folks. They had experienced rejection when they had started to transition from their families, from their communities. And then after time, they were able to build those inroads. Well, really, the community built outroads back to that person. They kind of reconciled with family and things like that. But this was a quote that stuck out to me. I believe at the time, this person was a 19-year-old trans man. When I was younger, before I accepted myself, I felt such a disconnect with my body and I loathed it. I literally hated my body, so self-destructive things were oddly pleasing. Substance use was like having some control over my body since I had been placed in this situation I didn't want. My mom accepts me now, but initially she just didn't know. It was such a new thing, so definitely I feared rejection by family and peers. The drinking made that stuff not matter to me. The drugs also helped that not matter. So especially when we're dealing with proximal stressors, but we can sit and understand logically that we are in a world now that is a little more accepting. We can engage in communities that are accepting. The feelings don't always come as quick as the logic does. And I really want to highlight that, especially in this situation, because what we've noticed in those necessary life adaptations, those coping strategies that aren't working so well anymore, it's not always rejection, it is the fear of rejection. And given the things our community has been through, I think a fear of rejection is very valid. It's very, very reasonable. My hope here is that it's something to think about, something to be made aware of. So we talked a little bit about self-care earlier. These are things we deliberately engage in on ideally a regular basis to help maintain and enhance well-being and health. There's many domains of self-care. And you don't have to do them all in one go. I wouldn't encourage it. That's a lot of work. But it's like physical. So that might be swimming. That might be walking. That might be tidying the house the best you can. Emotional, spiritual, professional. There's 6 of them, and I always remember 5 of the 6. So I think it's physical, emotional, spiritual, professional, interpersonal, and financial. I think those are the 6. And then they can look very similar. And self-care comes from what we need and value. And I mentioned this earlier, there is no failure in self-care. It can go quiet, but it never walks away completely. We've talked about this. The other thing, talk about the recovery model here in a little bit. It is very okay to lapse on self-care. Like I've said for, I think the 50th time so far, absolutely okay if we walk away from self-care strategies. We can always come back to them. It's also okay if self-care strategies don't work in a situation that we hoped it would work in. Then that kind of begs the question, what would we like to do? And I always try and phrase the question that way is, what would I like to do? Helps maintain a sense of control in the situation. And then community. I think especially for our community, a sense of community is critical. So it's so nice to see everybody here in a group. People who may not have been through the exact same circumstance that we've been through, but can empathize and sit with and listen to, digest and be with our unique experiences are wonderful, because it tells us that we're not alone in this world. And maybe I might be having a really hard time accepting myself and what I'm doing, but there is someone ideally that does, and they can hold that space for a little bit. I originally trialed this presentation with the Rainbow Refuge Group at EMCA, and so queer newcomers, and it was wonderful because we just jotted down what people do for self-care, the things that work, the things that don't work. And what I got to see was people turning and talking to each other and saying, this is what works for me. Does this work for you? Have you been through this before? Have you tried this before? It was a beautiful experience to watch. It went on for a couple hours. It was very collaborative. And I think that people walked away from that experience knowing that there were people around them that they might not know so well, but could empathize to the things that they had experienced, those unique circumstances and experiences. So very much a need for compassion, patience, non-judgment. We're going to slip on those things. It's totally normal, human. As long as we can feel like there are people around us that can help us, when we're down, or if we are down and we don't think that there are people around us, how would we like to if we could? And I talk a little bit about concepts of chosen family in this situation, especially as it relates to, necessary coping mechanisms and substance use. Chosen families are families that we deliberately engage in. They might, there might be individuals from biological family that we choose to have in our system. It might be friends. It might be caregivers and caretakers. It might be critical people in the community. These are people who the attachment, which I'll talk about here in a little bit, the attachment is secure, it's safe, it's unconditional. We feel comfortable to give love, but also to receive love. And it's kind of a bi-directional relationship. Before I talk about attachment, I'll talk a little bit about Rat Park. So back in the 20th century, there was a series of studies that were done. It's an interesting series of studies, but it was on basically the chemical hook theory of addiction. I think the same thing could be applied to, healthy behaviors that suddenly don't become healthy anymore. Like I had mentioned, movies, TV shows, work, volunteering, things like that. But basically, the study was performed on rats, isolated in cages with 2 bottles of water. One was laced with cocaine or heroin. The other was just regular water. And after the first week, I believe about 98% of the rats had died by overdose. And that was it. That proved our theory. Like, if you go into the hospital and you are put on morphine, you will stay on morphine. You will struggle with it for the rest of your life, which was a bit of a flawed design. So a fellow by the name of Dr. Bruce Alexander in the 70s created the concept of Rat Park, which was Disneyland for rats. There was color, there was family, there was more than one rat. There was there was stimulus, there was things to engage in the environment. It was multi-tiered. And the key findings were that rats stopped frequently consuming laced water. They did for the first week, here and there, almost you could refer to it as recreationally, but then they stopped all of a sudden. Deaths dropped significantly. I believe 2% of them had passed. Suddenly, the concern went away, and for the longest time we were trying to figure out why. And I think it is succinctly encapsulated as addiction. The opposite of addiction isn't sobriety. It's not. It's connection. It's not you are addicted or reliant on something. You are free from that thing. It is, you might be experiencing this, absolutely. And how would you like to connect with people to help mitigate that? Especially as far as like chemicals go. Chemical hooks are a casual factor in addiction. Pain is more profound. And addiction and substance use, it's the most concentric where there is despair. What we know is folks with adverse childhood experiences, adversity in childhood, they have, there's a greater risk for poorer health outcomes as they age. And in these circumstances, it's not necessarily the adversity or the trauma that is the direct cause of those outcomes. It becomes the effects of that adversity, the effects of those traumas, like shame, self-blame, and guilt. So that was basically the key findings of Rat Park and how we generalize to people day to day. And then attachment and the community. I'm not going to go over attachment styles. You're not being quizzed on this, I promise. But basically, there is, we can develop secure or insecure attachments. And secure attachments are safe, reciprocal, unconditional. This is a safe place to be. We develop them with friends, loved ones, family, community, what have you. They help us navigate relationships with others. We can also develop insecure attachments. Some people tend to, if it is an insecure attachment, they may avoid a little bit more. They may be a little more anxious. They may very much crave and want love, and then also be terrified of it at the same time. So questions to ponder for yourselves: how do you attach to loved ones, community, peers? Is it conditional? Is it safe? What does it look like? And then also, how do you attach to yourself? When you look at yourself as a person, looking at a body you live with and a personality you live with, in yourself, how do you attach to yourself? How would you like to attach to yourself? Is it a safe place? Can you sit with, you say you're carrying any particular stigmas or shames, can you sit with them and concurrently also feel secure in yourself? Those things are not mutually exclusive. And I talk about that as I will likely skip over to the recovery model, because I don't think people necessarily want to sit through equianalgesic charts and all that fun stuff. So we talk about harm reduction. It's the policies and programs and practices that help reduce adverse health, social, and economic circumstances. As a consequence, of the use of legal and illegal psychoactive drugs without necessarily reducing the consumption, this also applies to other coping mechanisms that we engage in. Somebody can engage in a lot of work in a day, 12, 13 hours, 14 hours of work in a day, whatever that looks like for a person. That doesn't necessarily mean that the person is profoundly unhealthy. It means, okay, you're doing that, got it. If you would like to do something different, what would you like that to look like? And then also, if you are watching a lot of movies, engaging in with a lot of TV, how can we do that in a way that's healthy? Maybe someone is forgoing like brushing their teeth or keeping up with activities of daily living, bathing, things like that. How do we hold those two things at the same time, and what does that look like for you? It's very individual for each person. It also believes that health care provided to you and the care from other people is not contingent on your moral standing. It's okay to mess things up. It's okay to get things wrong. Doesn't mean you're a bad person. It just means something is happening. This is more geared toward systems in place, because I can reflect on this back in New Brunswick. Fredericton specifically, the public mental health system. It was a really interesting situation because there were inpatient beds for mental health, there were inpatient beds for addiction. The beds for addiction you would be excluded from if you had mental health concerns, and the beds for mental health concerns you would be excluded from if you had active addiction. So if it sounds like that doesn't make sense, it's because it doesn't. These things go together. And that's what harm reduction recognizes, is that how would you like to engage with life meaningfully while also understanding that there are going to be things that are struggled with. I actually think harm reduction originally came from diabetes research. If I'm like flipping back through a textbook in my head, because it was the concept, it was that or cardiovascular, but basically it was the concept of you had a heart attack and you lived through it, or you're diagnosed with type 2 diabetes, what have you. That's not the end of the world. That's not the end of your world. You might have to take, 81 milligrams of aspirin every day. You might have to start taking insulin. Your life doesn't stop because this thing has happened. And it's the same with psychological and mental health well-being. Life doesn't stop because you fall into that space. People can engage in very meaningful lives and still do things that are not necessarily healthy for them. Ideally, as long as there's an understanding that this isn't necessarily so healthy for me, but it's what I know how to do right now. And eventually things might look a little bit different. Concurrent disorders, I'll touch on briefly, which is basically that concept of things usually come in pairs. Somebody isn't just using substances and then, or avoidance coping, for example. That's not just a lackadaisic thing usually. Somebody might also be experiencing concurrent grief, depression, anxiety, post-traumatic stress. And the shift to a recovery-oriented approach understands that these things likely are going to come in pairs, and it's important to recognize that they're coming in pairs, whether that be for yourself individually or advocating that to healthcare providers starting to come around. I think, they're not mutually exclusive. Somebody can, just because somebody's doing something that is not healthy does not mean that they are fundamentally unhealthy. I talk about naloxone a little bit, especially in this current climate, as a form of harm reduction, especially with opioids. And I always like to touch on this piece, even if I've only talked about substances a little bit. If people are unfamiliar with naloxone, we call it an opioid antagonist, which means it quickly reverses the effects of an opioid. I've had to administer it a couple times, and just knowing what it is and how it's used can be useful sometimes. But basically, it very rapidly and temporarily affects the use of an opioid. Affects the use of an opioid by stopping the brain from recognizing that chemical. Somebody will very quickly go into withdrawal, but it is life-saving and crucial. It is typically administered in a syringe, so it's intramuscular. My apologies, I'm on a busy street and there are sirens, so I'll wait for that to go. But naloxone is intramuscular, intranasal, in the nose. So it's intranasal, intramuscular, into a muscle, intravenously, into a vein, or subcutaneous under the skin, teeny tiny little needle. The most common ones that I think people see are intramuscular. It looks like a needle that somebody would get if they were getting an immunization. And it very rapidly stops the actions of an opioid. If you ever have to administer it, and I'll leave this in for people, be prepared for the person to wake up and quickly experience confusion. The use of naloxone can throw people into withdrawal. I've had to administer it before at like raves, whatnot. We used to call it Future Forest back in New Brunswick. It was a kind of a weekend-long party situation. And people would come up and then they would just come up swinging, you know what I mean? Because they were very quickly put into withdrawal. I think this is also an interesting metaphor for psychological self-care. Oh, a chat thing came up and I can't quite see it. Oh, yes. Great, wonderful. I think this is also interesting for psychological self-care because I talk about, caution, especially surrounding recognizing that what somebody might be doing is not so helpful, can very quickly bring on feelings of shame, blame, and guilt. So kind of in parallel with naloxone almost, where naloxone would very quickly bring somebody into withdrawal, paying attention to the things that we're doing that might be harming us might quickly bring on a little more harm, and that might promote further avoidance. So the goal here, I hope, is to recognize it as it is, especially psychologically, sit with it for as long as you can, understanding it's not a permanent thing, and then that once again, how would you like to deal with it? If you could, what would it look like? Whatever the concern may be. And I believe that brings us to just about the end, some community resources. As far as multiculturalism goes, there's EMCN. I work here, a little biased, love the system. There's also the Multicultural Health Brokers Initiative. If anybody is having a hard time navigating their own personal, like their personal culture and Canadian culture, they're wonderful for bridging that gap. Pride Center of Edmonton offers advocacy navigating gender health, and they also have support groups. CHEW and Outreach provide, interestingly, access to necessities, STBBI testing, sexually transmitted and bloodborne infections, barriers for homelessness and poverty, and support for sex work. It's the only system I've seen that supports sex work. So I'm very happy that exists. And then also you folks exist as a resource too. Aging with Pride, to my understanding, it is very much in finding housing for people and supporting people in that capacity, I believe. So that is a wonderful system as well. And recovery model, I just spoke to this. Yeah, the final piece I'll say here as a reiteration, people can experience symptoms of mental health concerns while still living a meaningful life. These things aren't mutually exclusive. We have dark moments, absolutely. It doesn't mean that that thing won't pass if we can sit with it and if we can care for ourselves while that's happening. And that brings me to the end. I'm more than happy to have a discussion, more than happy to answer some questions. If anybody has anything.
Quickly, before anybody has any questions, just quickly say thank you so much, Jed. Greatly appreciated. I do have some questions myself, but I just wanted to start saying by thank you so much for this presentation. Very helpful about our community. Helen, you have a question.
Yes, I was interested in the attach model. So if folks don't feel comfortable with their identity or haven't been parented well and grow up with severe adverse childhood conditions, then they may go to folks who are also not necessarily living healthy lifestyles. So I'm thinking about, gang members, organized crime, and if you could just chat about like the attachment model you have within kind of an unhealthy system. Is that so because that's what like what's the theory or the rationale for that?
I see it run in two different directions. The first being, let's say somebody has more of an avoidant attachment style, and then they see a lot of the things that they value in somebody that is very secure in their attachment style. They might value that, they might look up to that, they might try and engage in that the best they can, and then they will, obviously it creates a lot of tension and will, kind of push away from community, especially if, someone's sitting with that insecure attachment style. The other being, as far as affiliating with people who also might be struggling with attachment, is I think I very much pain understands pain, hurt understands hurt. It might not be a verbal thing. It it might not even be like an outward expression of emotion, but I think folks that are more sensitive or folks that are sensitive as a result of the things that have happened in their childhood can see that in some degree play out in others, mostly because we're monitoring for danger more frequently. That's an interesting like clinical byproduct of adverse childhood experiences, is we pay more attention to the things that are happening around us. And one of the things we can do is pick up on the hurt from other people. It's interesting because, we can see it, and then also that person might provide theoretically some kind of care because they know they can see it. So we might start to affiliate with people who are also struggling with trauma, adversity, attachment. And, we want to sit with them because they understand. Yeah, hope that answers that.
Thank you. Larry, you got your hand up.
I do, and thank you very much for stimulating talk, Jed. My question has to do with the way we presently manage harm reduction and naloxone, in that if you are taking the drugs out of despair and you wake up to an environment which is equally despairing. In other words, if you don't have the other support components of a healthy support system in there, it seems to me we're as much treating symptoms as any other model, like recurrent emergency room attendees and so on. Can you comment on that concept of the need to place harm reduction in a larger and healthier context than it appears to me to be the case at the moment?
Absolutely. I, especially with harm reduction, should have spoken to that. So thank you for asking that. There's two particular things I believe in. One is a wraparound approach. The other is peer support systems. Yeah, it's not lost on me that in an emergency situation, you're going to go to the hospital, you're going to, that drug's going to be flushed out of your system, and then you're going to be sent back into the exact same environment that you came from, which it's pathologizing the person and it's treating the symptoms at the same time. What we are starting to see, I hope, is an emergence of a wraparound approach. I'm starting to see it more so in safe injection sites. There are social workers, therapists on staff, what have you, that you can go into that center and use those substances, but you can also talk to somebody. You don't have to, you're not forced to. But ideally, the experience is one of being less alone. I've been talking a little bit with the MCN as well. They're very interested in starting in their system, peer support groups. So for people that they are actively using, there is a place where they can go that they know is not going to stigmatize them. Ideally, safety in the short term to stabilize, but then to also redirect and orient the person to a sense of community. And even here at EMCN, we take a wraparound approach, which is very nice and refreshing to see. So, people I work with, I am the therapist, and then there is also a social worker that's checking in. If they're a young person in the school system, there is a support worker in the schools from EMCN dealing with concerns that might pop up. So harm reduction approach is not, naloxone is a wonderful first step. We need it. It's life-saving. But yes, absolutely, we have to deal with the after effects, which typically look like isolation, treating symptoms. Yeah. So I very much advocate for peer support systems and wraparound approaches. Now, you can't make somebody engage in those systems. My hope is that if they're available and widely known and repeated quite frequently, somebody will eventually take the steps to engage in those care systems. Hope that answers the question.
Thank you. Jan, you have your hand up.
Jed, you have the most amazing, calming voice. It's just such a treat to hear you. My question is more about the self-care and the routines that may have developed, and you're progressing along on a daily basis of exercise routine, and then boom, all of a sudden you don't. And I'm just wondering what happened. And you've mentioned many times that it's okay, that you're not bad, that it's fine. But is it something that like happens in the brain where you just switch, that you're just not going to do that?
Do you mean in terms of like kind of progressively, let's say exercise, for example, like progressively getting more into it?
Or yes, or just even stopping completely.
Oh, sure. Yeah. Absolutely. It's very quiet, I think. You know, we'll say starting exercise, somebody might start like 10, 15 minutes a day. I've seen it play out before, especially if someone's trying to swap behaviors, that becomes a little more apparent. So if somebody is drinking quite excessively, they'll start to exercise, but then they'll exercise whenever they feel a craving to drink. So, 15 minutes becomes a half hour, can become an hour and a half, becomes, in some cases, I've seen like 4 hours of cardio a day. And then the sudden stopping of that, I think, occurs when something has happened, one of those proximal stressors that's overwhelmed our system. First, to some degree, that excessive exercise or whatever we were engaging in, it was holding some kind of function. And now we've encountered something that it can't contain any longer. So people can absolutely suddenly stop doing the things that they can stop engaging in necessary life adaptations if they're feeling very overwhelmed. It works the same with self-care, I think. Things like that, they have a very stunning response, I think. It's like a system shock. So even the things that we were doing as a survival technique, it's not adequate to deal with the situation that we're facing anymore, or we don't feel it to be. So then we would outright stop. I hope that answers that.
Yeah, thank you.
Yeah.
I do have, oh, sorry, Joan, you've raised your hand. Please go ahead.
Hi, Jed. That's amazing speech and talk. I loved it. I learned so much, as I always do, and I listen to the professionals. I have a question, or I just wonder your thoughts on the whole harm reduction. I've been hearing two sides of the coin quite often. Some people say harm reduction, for instance, in the case of substance abuse, is not really good. Like an alcoholic wouldn't be given small doses of alcohol for the rest of their life and, expect that it's going to help with their addiction. So I'm curious, as to someone who is in the field and seeing the things that you see, where you might weigh in on that issue.
That's a good question. I am slightly conflicted on the whole thing because I've heard a lot of I've heard a lot from both camps, a lot from service users, a lot from clinicians, kind of the sense of, especially around the decriminalization and legalization of various substances. Very torn. My concern in harm reduction becomes, if somebody's going to use it, can we get it to them safely? I think that fares more effective than promoting things kind of on the black market side. My concern then becomes, obviously, and I've heard this from folks before, and it's very reasonable, what happens if this promotes people using substances, like it's just available now. I think cannabis was the biggest trial that we've seen in like modern history, you know what I mean? There was when Cannabis NB first started in Fredericton, there was like lineups wrapping around the building for like the first 4 days. I remember that. So that there was this part of me that's like, if we do this, people are going to run at it. I think there's a piece that we're missing in self-care, and I'm starting to see it as, it's not even necessarily people who fall through the cracks. It's just all of the stressors that we face day to day that did not exist historically. I think those things have to be addressed in tandem, almost as this like third intermediary between having all these things in harm reduction is good versus having all these things in harm reduction is not good and harmful. We're missing a step in between. I think it is addressing systemic and systematic barriers. So it's a very tangential way of saying I believe in equity. But if I'm being honest, my verdict isn't completely out on either camp, just because I've seen both work, I've seen both not work. So I think we're missing something, and I really wish I could give you a more succinct answer. But truth be told, I don't know that much. And I don't know if any of us know that well. This is an experiment almost that we're still playing out, I think.
Thanks, Jen.
Thank you. I'd just like to talk for a quick second on the difference between self-care and avoidance coping. And
Yeah.
for many years, I was professionally closeted because I dealt with a lot of fairly right-wing businessmen in the United States. And so I would go and not be who I was and come home and think that I had successfully coped, but that successfully coping was isolation and that sort of thing. So I think that whole dialogue about what healthy self-care is and the difference between it and avoidance coping or adaptation is a really important one, because it took me quite a while to recognize that I wasn't doing self-care, I was avoiding a lot of stuff. So from a personal point of view, that was really important. And the connection piece, absolutely critical. I can't see, it's very difficult for me to see somebody becoming healthy without having some connections in the community and some close people that they can count on, they feel safe and they feel comfortable with. So those were my 2 cents. I just want to say thank you so much. I think this was such a good presentation for our community. We all know people who have successfully overcome challenges and people who are still struggling, and it's so important to have this. Helen, you've got a quick comment. I'll let you in at this. Your hand is up.
Oh no, I was just clapping. No, I just want to say thank you. This was wonderful. I love Jed's style of presentation, and always very informative every time I listen. So that's it. Thanks.
Okay. Thank you, everybody, for attending today. Do you have a last quick 1 second or 1 minute takeaway for us, Jed, or have you done your presentation in full now?
I think the last thing I'll say is a lot of the things that we do and engage in as far as surviving, we do without thinking about it. Very much, Eric, to what you were saying earlier. And I think, well, the verdict's not out on the mind, we don't know much about it, but I think it is so that the mind doesn't have to focus on it. So like I had said, if anything, I hope that folks take away an open, compassionate, consideration of looking at, what exactly you're doing, the things that might be kind of playing out that we're not aware of. Can you be made even slightly aware of them? And if you are made aware of them, what would you like to do about it?
Super. With that, I just want to remind everybody that next week our presenter is Michael Magnuson from the Art Gallery of Alberta. He's talking about their senior programming. There's some great things that are going on at the Art Gallery, so I encourage everybody to join in on that. Again, I want to thank Jed so much for today's presentation. Very, very good, very helpful. I see Karen giving us the cheer. And if anybody wants to stay on, we are going to go into a breakout room for a few minutes just to see if Jed would like to give us any final feedback. But if we'll keep this main room open until 12:15 in case anybody wants to talk among themselves. So with that, thanks again, Jed. Thank you, everybody, for attending, and we'll see you next week.